Okay, great. That sounds good. Well, welcome everyone, and thank you so much for joining us for this special rover Sparrow Acro rocket presentation. We're very, very excited for the panel we've assembled here today. And with that, we'll dive in talking about parenthood and radiation oncology. If my slide will let me advance. So today we'll be doing brief introductions. I'll introduce myself and my co-moderator, Emily McDuffie. We'll review some of the pertinent literature to parenthood and radiation oncology, as well as recent policy changes, such as the new ACGME parental leave policy and ABR's response to this. The most exciting part is our panel that we've assembled today, so we'll have plenty of time for question and answer. And then we'll just have you guys take a quick post survey if you're able to give feedback on the session. So I am Claire Baniel. I am a third-year resident at Stanford. I am also the SWARO Advocacy Chair for 2022-2023. And then I'm joined today by Emily McDuffie, who is also a PGY3 resident at University of Pennsylvania. She's very active in the Association of Residents in Radiation Oncology, or ARO, and is currently their Global Health Chair. This is our wonderful panel that we have assembled today, and I've put their pictures here, but we'll actually have them jump in and introduce themselves more toward the Q&A time. But we're so excited that they were able to take time to join us today for this group. And with that, let's talk about our important topic, which is parenthood and radiation oncology. The first thing I want to just emphasize is that even though we talk a lot about pregnancy and childbirth, this isn't necessarily a gender-specific issue. So when we look at data that's been published, we know that over 50% of residents will choose to grow their family during training, regardless of their gender. And part of this is because medical training spans a time that most people are in their 20s or 30s, which is also when most people choose to start or continue to grow their families. With time, we've seen the evolution of parental roles actually changing as well. Historically, a lot of women physicians have been reported in the literature to perform more domestic tasks at home, including child rearing, but we also see that trend starting to change. So there was a really interesting paper that was just published in the past year discussing paternity leave or partner leave, especially in radiation oncology. And one of the really interesting things to note is that even though home roles are changing, some of the pressures remain. So a lot of the residents that were surveyed noted that even though they were offered paternity leave, they often felt pressured to cut their time short due to perceived pressures to return to work. So what can we all do to hope to kind of normalize parental leave regardless of gender, and how can we improve parental leave for all? So one of the important things, we have to talk about whenever we think about starting families during residency or medical school is the impact on board certification, as well as the impact on career decision making. So what's very interesting is, as I mentioned, since most people choose to start families in their 20s or 30s, there still is some timing to be considered in terms of how this would affect residency training, how this might affect early board certification for radiation oncology. And there's been some really great papers. The one by Laura Dover here on the bottom left actually described that early career female radiation oncologists often report delaying their board examination or delaying pregnancy in order to take their board examinations. So actual decision-making for family planning is impacted by some of those rigid schedules that have previously been in place. Furthermore, when we look at all oncologists, not just radiation oncologists, Emily Murfield and others did a great job characterizing some perceptions and barriers to pursuing academic versus non-academic careers in oncology. And even though we find that career aspirations remain the same in terms of research goals and publications, they actually found that women often cited having trade-offs between deciding between work and home as a reason that they were thinking of leaving academia in oncology. So these are important topics for retention of a diverse workforce that we're working to retain. So on that note, how can we actually support radiation oncology parents and oncology parents in general? So when we look at parental leave policies, one of the best ways to make systematic change is to structurally uplift everyone involved in the process. So when we look at parental leave policies for residents in specific, because medical school policies are typically a little bit more heterogeneous, up until 2021, a lot of the parental leave policies were determined by the individual program without a lot of recommendation or oversight by ACGME or American Board of Radiology. So excitingly, in 2021, the American Board of Radiology did update their residency leave policy. And this is important in specific because the ABR oversees determination for determining graduation eligibility as well as ability to sit for your board exams. So they announced that they were updating their policy to reflect that residents could take time off during training of an average of 8 weeks per year and still be eligible for their initial board certification. Right around the same time, so ACGME announced it in 2021, but it went into effect in 2022. They approved 6 weeks of parental leave, not only for radiation oncology, but for all residents, for parents. So this is regardless of gender. It's 100% salary equivalent provided by the program, starting on day 1 of residency. And they also note that insurance benefits should be continued and policy should be shared openly with all who are interested. So some of those things are highlighted here, and I've actually copy pasted the exact verbiage from the ACGME policy. So you guys have that for your reference. But the big highlights, as I mentioned, is that your healthcare benefits are to continue. You're able to start immediately in comparison with if you have statewide parental leave, such as FMLA, often you have to work for your employer for a year prior to that kicking in. So that was a really huge change for programs and for residents nationwide. One thing I think we'll talk about a little bit with the panel is even though these are absolutely wonderful changes being implemented, there are still some questions that remain. And I think one of them that we can touch on when the panel discussion starts is where that 100% salary equivalent is coming from. So ACGME recommends 100% salary equivalent. However, how programs and departments are able to meet that requirement, there's a lot of flexibility that's left up to programs. So, and that I think can be a challenge even so for departments because every department has different resources. With that, I'm actually going to turn it over to Emily McDuffie, my co-moderator, and she's going to talk a little bit more about the ABR residency policy.
Yeah, thanks, Claire. So as Claire mentioned, prior to 2021, policies were very, very heterogeneous across different boards, including the ABR. In 2021, this was a really important implementation of across radiology, radiation oncology, nuclear medicine, to formalize what leave looks like in order to have residents be eligible for their initial certification. So as Claire mentioned, this is 8 weeks per year averaged, over the 4 years. So that's 32 weeks. It does require program approval, but the time off also has been specified in this policy, whereas before it was very kind of generic, but specifically for vacation, interviews, but also thinking about bereavement, parental leave, caregiver leave, and personal medical leave. These are specific reasons for time off that weren't previously even mentioned or specified. And so I think the benefit of this is to help with uniformity across training programs to try to give trainees across the country some level of confidence that they can take this time off without having to extend their training. Next slide. So these are two bulletins, really just trying to highlight that organizations like ASTRO, AAWR, are being really vocal in their support of this policy and of really supporting residents through their training. and even pushing for additional support. So the AWR would love to see having 12 weeks of paid leave as a formalized policy. And I think really just want to emphasize that it's very promising to see these large organizations advocating in these public spaces, and hopefully just normalizing what it means to be a parent and have time that you need to take away from your training to take care of your life and your family. So this is something that I think has been much increased across medicine in general, but it's really great that we're seeing our field in particular really emphasize these points. So along with parenting, some people choose not to become parents during their training, but unfortunately, one outcome of this can be infertility. Particularly in women due to maternal age. Unfortunately, a larger percentage of physicians compared to the general population experience infertility, likely because of this delay in childbearing. And there have actually been a few surveys looking at trainees' knowledge and desire for knowledge when it comes to infertility, when it comes to fertility preservation. And there's been demonstrated to be quite a gap, unfortunately. It's not something that people are discussing with medical students, very infrequently discussing with residents. There are options for residents who would like to think about potentially preparing for pregnancy later on at a later age. Elective fertility preservation is actually quite an excellent option with very good outcomes after ovarian preservation or embryo preservation, for example. Unfortunately, these can be very, very expensive when not covered by insurance. And right now, there's very little data regarding insurance coverage. In surveys of residents, it's suggested 3 to 12%, although a majority of respondents are unsure of their coverage. So I think this is still a space that needs more exploration. But I think in general, bringing visibility to this issue and advocating for insurance coverage is really important. And from a departmental level, trainees do require time to go through this type of process. And so being able to make the space for physicians to be able to go to appointments and to be able to put the time into this is really important, and something we also don't have good data on how programs are able to support that for residents. All right, well, hopefully some of that background was helpful. I think what we'll do now is have our panelists introduce themselves. And why don't we start with Dr. John Plasteris?
Hi, I'm trying to figure out how to turn on my video here. Oh, someone said I stopped my video. Anyway, hi, I'm John Plasteris. I am a radiation oncologist at Penn, and I have the pleasure to be married to Dr. Neha Vapiwala, one of the other panelists here. I will just say a couple of quick things, Emily, that, you know, as a sort of like hashtag RadOncDad, you know, my sort of philosophy is to try to, you know, support, you know, the sort of endeavor of women in radiation oncology and medicine in general, and do sort of like everything we can as dads. So that's my overall philosophy. As you know, I have some very specific sort of thoughts on the normalization of parenthood in radiation oncology and academic medicine in general. And I can sort of speak on that a little bit.
Great, thank you. Dr. Everett?
Hi, my name is Ashlyn Everett, and I am a recent graduate. So I finished my training in 2020, and I'm in private practice in Huntsville, Alabama with Alliance Cancer Care. I have a 2-year-old daughter, and so I had her at the end of my training right before I started my job. So definitely in the middle of boards, in the middle of transitioning career, and I'm happy to speak about that. if anyone has questions.
Great, thank you. Dr. Jagsy?
My name is Reshma Jagsi, and I am I'm the chair of radiation oncology at Emory. I'm sorry, I'm trying to speak a little quietly because I'm in a weird echoey golf club where we're having a Cancer Institute retreat. I am the proud mom of a 17-year-old daughter and a 13-year-old son, and really started becoming interested in these issues when I was a pregnant chief resident, and the ABR at the time circulated by fax only to program directors and chairs at the time a notification that leave from residency training was going to be limited to 4 weeks per year, and that people could roll it over from year to year, that the chief resident class, that I was already pregnant, chief resident class, was going to be allowed an extra 2 weeks of grace, that we were going to be allowed 6 weeks. This is after, of course, I had permission from my institution, which had a policy of letting you take your medical leave plus your vacation in a row to take at least 10 weeks of leave. Now I was being told I'd have to keep it to 6 weeks of leave if I wanted to be board eligible. And so that really ignited in me a desire to advocate and change things. I was chair of Arrow at the time and got a lot of emails from my colleagues who were residents in similar situations saying we needed to do something about this, and really ignited a whole pathway of research that then sought to document the impact that this has had on fertility and wellness and gender equity. Because although parental leave is absolutely an issue that affects every gender, it is important for us to recognize that there is a gender division of domestic labor in our society, whereby women are spending more time on domestic labor. And if we don't allow men parental leave, there ends up a perpetuation of that by creating an expert parent. And so this is a gender equity issue, because if we don't give parental leave to all genders, we're going to reinforce that gender division of labor that then persists throughout careers. So I think it's a wonderful success story of what can be done in terms of changing policies with evidence. We wrote a perspective back when I was pregnant. My daughter's 17, so that tells you how long ago it was. There were things that the New England Journal told us we could not put into that editorial at the time because they were too crazy. Competencies-based assessment as opposed to time-based assessment of training. And a little over a decade later, they actually took another perspective from the same group of co-authors and actually allowed us to say that stuff. And that was followed by changes in national policies that we've seen. And so I think this is an illustration. And then, of course, there have been so many important studies that have been led by members of our field that have shown just how we can drive the field forward with our initiatives and our research. So really excited to be here.
Great, thank you so much. And your audio is great, by the way. Dr. Beltran-Ponce.
Hi, I'm Sarah Beltran-Ponce. I am a fourth-year resident at the Medical College of Wisconsin, and also serve as the vice chair of SWARO and have two little ones. I had my first baby at the end of my intern year, and then transitioned to radiation oncology with a 7-week-old, and then had a second baby during my PGY3 year, who's about to turn 1 next week, which is a little unbelievable to me. But a lot of this, and having some poor leaves and short leaves, more less than what I would have liked to take, has also fueled a passion to continue building on some of the work of others from a research standpoint, as well as really seeking a good balance within my own life and career as a working mom.
Thank you. Dr. Small.
Yeah, thank you for having me. I'm a radiation oncologist in Chicago. I'm chair of the Department of Radiation Oncology at our institution. I'm also the Cancer Center director. So having a lot of direct reports and having this issue is incredibly important to me. I was going to say I had 2 kids, but I didn't have them. My wife had our 2 babies during both internship and residency, and the oldest one is actually an attendee on here because she's a radiation oncology resident. So I've got a vested interest in getting grandkids, no pressure. So that might be one of the major reasons I'm here now. Just kidding. I have a lot to say about this, but I think one thing I will say as leading department, and Reshma might be able to add this to, and all of us have leadership things. I really, radiation oncology is the best specialty ever. It's a wonderful specialty, but it does lead itself to, I don't think we should be able to handle our clinics without residents. So that's how I've always had the residencies done. And that's not how it used to be. In fact, when I was when Christina made it home from her hospital, I couldn't go help her get home with my wife with a C-section because I had to be at work. So although it seems like we got a long way to go, we have got a long way. I got yelled at for not being in the ICU as an intern the day after she was born. I'm like, and the response was, "You didn't have the baby." And I'm like, "Okay, thank you." So I think we've made some strides, but we certainly have a long way to go. And I'll say one other editorial comment is I really hope that, I really want to say thank you to everyone that's working on this. The amount of changes that have happened the last couple of years are dramatic. And I think there's a real push to do this. I know I was involved in Resolution 13 for the ACR, and it was uniformly accepted well. So thanks again for everybody's work.
Great, thank you so much. And we will round out our panel with Dr. Vapiwala.
Hi, everyone, and thank you so much for organizing this, Emily and Claire. So I'm Neha Vapiwala. I'm a Vice Chair of Education and a Professor of Radiation Oncology at Penn, along with John, and get to work with Emily as well. I'm also Dean of Admissions at the medical school. So, feeling the impact of all of these aspects, in particular, the impact of parental responsibilities, even among our medical student class through our residency training, and then thinking about it in my own life. So both John and I, we had our first child who just recently turned 13 when we both just started as faculty as assistant professors. Our second child when we were associate professors, and my third child when I was a full professor. And I can tell you the perspective that I had during each of those maternity leaves in terms of exactly how relaxed versus unrelaxed I was pretty dramatic. And of course, when you're talking about being a trainee, whether you're a student or a resident, it's an incredibly vulnerable time. And so I think, again, I look forward to the opportunity for us to chat today about how we do normalize and support all parents with all backgrounds and experiences at whatever point in their training they are. And I had the unique privilege of being in the room when the discussions were happening for the ACGME change, as well as ASTRO, and the importance that the board support this and be verbal about it, because I think, historically, perhaps that support has not always been front and center. And then, of course, the great work that the ABR did in essentially making this possible. So, but still lots to discuss on this. So thank you again for having us.
Amazing. Thank you all so much. We really, really appreciate having your voices and perspectives here today. Can we go to the next slide? Great. So let's start out, get some more perspectives. I think our first question centers around timing. As Dr. Vapiwala, just alluded to, the timing of having children can be very different depending on where you are in your training and in your career. And so we'd love to hear from you all about your thoughts on differences in, starting a family before residency, during, afterwards. And I think in terms of organizing, we can just have people speak up. We can have as many or few people would like to answer questions for each of our questions, and we will try to get through all of them by the end of our time today.
So Emily, do you want us to answer when's the best timing?
I would love volunteers to discuss their thoughts on that.
I don't really have a great answer to this, but Amy Pruitt, who is a neurologist at Penn, who was like the co-mentor with me when I did like the doctoring course for the medical students. We kind of had a little session on this, and the medical students like, when's the best time to have a baby? And Amy Pruitt was like, there's never a good time, so you might as well just do it. And I was just cracking up. I was like, okay, well, if that's sort of the best we can offer, it's a little tricky because, in my opinion, as you alluded to, like the time that you can sort of like take off becomes more and more, I think, permissive as you go from medical school to residency to junior faculty to more, senior faculty. But, that's sort of not really aligned with, the biological clock that you alluded to earlier, right? So I don't know. I feel like there has to be a compromise to this, and there's like never a good time. So I don't know. I think that you probably need to just like sort of go when you think you're ready to have a child. Like I don't know. I don't really have a good answer. I'm sure someone else has a better answer.
Well, I kind of had similar advice from an advisor that nothing in medicine can fit perfectly. There's always sacrifices. So you should make your family planning work with your life and not compromise one versus the other. As much as everything in life is a balance, it has to be a balance. So I think this is incredibly personal to each individual situation. So I can just kind of give my testimony, so to speak. I was married at the end of medical school, and then my husband and I actually lived long distance for several years. So having a baby was not practical. And so my decision to have a child during residency towards the end was driven both by timing of my husband then moved back to where I was training, as well as at that point in time, I was also going to have more research, and I was going to have more time off, and I was going to have more clinic coverage, and felt like the support of the program would be a little bit stronger for me to be off during that time. So I actually found out I was pregnant the day before I took my physics and rad bio exam, which I would not recommend testing because you're not going to get anything done before you study once you find out you're pregnant. So then I would say having a baby early career has its own challenges. So depending on your specific situation, finding clinic coverage, being out of the office, and the particular financial structure of your job, however that looks, will be different. So FMLA is a potential for time off, but in my particular circumstance, all of my time off is bundled under one. So I don't necessarily have a maternity leave, but I have a very nice vacation in my contract with my current employer. So that would be part of what I negotiated, was actually if I didn't use a week of vacation, I could roll it into the next year so that I could actually prolong potentially a maternity leave in my current position. So those are kind of factors that went into how my family has made a decision to grow our family. And those are just some things that I can answer more questions about, but that was my personal experience.
I think everyone gets that same advice of there's never a perfect time professionally. So choose the time that's most perfect for you personally, and when it feels right from that standpoint. Speaking just from the perspective of someone who's had 2 kids in residency and is still kind of in the thick of that resident life, there certainly are challenges. And I think one of the biggest ones is just the lack of ability to outsource. I think you have a lot more financial freedom later on in your career where you could outsource cleaning, yard work, those types of things that tend to build a little pressure more as a trainee when your time is stretched with studying in clinic and parenting. So you just have to have grace with yourself if you choose to have kids during your training. I always have at least one load of unfolded laundry somewhere in my house that I just will live with. And sometimes we have chicken nuggets for dinner because I didn't have time to make something that looks really nice. And that's just the way that life is. But I also had the benefit of not having to close my own clinic in order to kind of take a leave or take time off. I could flex some research towards the end of leave to extend the time that I had at home with my family, which was really nice. And then also just am able to expand my family more in the future if I choose to, because I have a little bit more wiggle room as far as the biological clock goes with starting a family in my late 20s, which I think is a benefit from my perspective as well. But I have the bias of being close to family in addition, which I think plays a big role into those decisions. Both my family and my husband's family live within 20 minutes of my house. And so I have a lot of support from that standpoint too, which was a big factor in deciding rank lists and things from the get-go, knowing I wanted to start a family as a trainee.
Yeah, I guess I can answer. I kind of go back to what John said. If this is a personal decision, there's no right answer. I know that what Sarah mentioned about outsourcing, I put myself through med school. Having a baby during med school would have been incredibly financially difficult. I did get married in med school, but it would have been financially difficult. I do think there's one thing that this brings up. Whenever I have a resident who goes out into the workforce, I look at their contract. And this is part of recruitment. I think that you should be looking at these kind of things and seeing where you're going. No one kind of thinks of that, even if you're not married. If you're going into a 5-year residency, you might get married. This might be something to do. So I think I personally, for my institution, want this to be something that we can use as a recruitment tool, both for residents and attendings. And I think it's financially very viable if you do that. So like I said, I don't think there's ever a good time. There are some obviously logistical issues when it comes to support, but we for some of the same reasons chose to have our kids during residency, mostly because we thought it was time and we would figure out how to work it out.
Thank you. I think there was a really good question in the chat that's somewhat related from Amy Lee. She's asking, in academic institutions specifically, though I think this could also apply to private practice, is there discouragement from attendings taking a full 12 weeks of parental leave?
If there is, you should find a different job, personally.
I'll just say, when I was, as I said, very early career and decided to take my first maternity leave, the full 12 weeks. And this sort of gets to what Ashlyn was kind of referencing, where, there's different pressures where you think you might have more freedom, but, there's this perception, okay, you're just starting your career and now you're going down this other track. And I hate to think that that's how things would be ever phrased or viewed, but that's exactly how it was seen, as if it's an either or. And I remember, even though I had sort of that similar policy where it comes out of your vacation time, and that's how they have effectively cobbled together the leave within the academic department, that the perception or the judgment that I felt when I would tell people I was taking 12 weeks, the comment usually came within seconds of, oh, wow, you're taking the full 12 weeks. Huh? And I thought to myself, have you ever met a 12-week-old? I'm pretty sure they're not able to be independent beings at that stage. So the simple fact that that would even be considered some sort of luxury speaks volumes to, I think, the environment and the culture that existed. And even, I think, over the course of the other children I had, the attitudes, the way in which people, again, looked at this became much more supportive and not judgmental, and or at least less judgmental about these decisions of how long you take. And of course, again, as a faculty member, I realized I had those 12 weeks to take, and that's not the case for trainees always, but just the simple fact that even that was seen as some sort of luxury. So that's one thing I'll mention. And then the other thing, interestingly, is that as part of our sort of parental preparation, we went to the hospital and took one of those classes prior to the delivery of the child. And one of the other families that was there during the hospital tour, and of course, was a family where her father was, in fact, an attorney, who admitted, and I give him credit for this, that he was part of the group that had written the policy for leave, specifically for my university and specifically for faculty, and that the assignment at the time had been write a policy that is legal and that follows the law, but that maximizes the time that the clinician will be able to work over the course of the year. And so that's why it's coming out of vacation, right? That's why it's coming out of this time that you would otherwise take, and that's part of the year-to-year contract. And there is no, unfortunately, as far as I know, in most academic centers, no rolling over of days for faculty, right? So it's use it or lose it. So you can't kind of pile up stockpile some of your weeks, knowing that you're going to be delivering in the following academic year. So those are just some initial thoughts for that question.
Yeah, I was like completely floored by that, comment from the lawyer. And I was like, it's like, figure out the most draconian policy possible to like torture Penn faculty. I hope none of the lawyers from Penn are on this call right now, but it was pretty ridiculous. And I think that the one like potential saving grace for Neha and I is that, the leadership in our department was like willing to kind of like stretch things a little bit. And I would say that, you know, as you look for jobs and, you know, look for who your leadership, you know, the leadership is going to be, you want to make sure that they have sort of a quote unquote family friendly attitude. Not 100% sure how to ask those questions, but we've been fortunate that they were able to kind of like give us the benefit of the doubt, you know, especially with my 3 days of paternity leave, which was, you know, again, that was sort of the old days. Hopefully things are better these days, but yeah, the health systems have zero, you know, motivation to make a generous maternity policy. So you kind of have to just push in a way that is sort of like appropriate. But again, I think as Bill will attest, you know, you want to get good people. 3 months out of someone's career is like a snap of the fingers for someone who's great. So like, I can't even remember the maternity leaves of my colleagues that I covered. They came and went. So all this fuss is, I think, really minor compared to getting really good faculty. So I think, you know, a chair who really is forward thinking can, you know, look through that. All right, go ahead, Reshma.
No, sorry. I think the other really interesting thing is that there is a silver lining to the epidemic of physician burnout, which is that it has finally given health systems an incentive to think a little bit more long-term about issues like this, that in fact, there is a growing realization that a workforce happy and has more healthy work-life integration is actually going to perform better. And so if we're striving for excellence or productivity, actually having well-being and equity within our workforce is good for us as leaders as well. And so I think what you want to do when you're searching for programs and jobs is to go to organizations that have embedded that into their culture, because I think that has seeped into different organizations to different extents. I think overall it's increasing everywhere, but that's something I would look for.
I actually think that's a perfect segue. I think we have a slide on family friendly, so I might sneak forward to it a little bit. Oh, maybe I didn't put it in. We've been sort of talking about some of these different things like length of leave and details of the leave. And I think family friendliness kind of extends to that as well, because a lot of these policies are determined by the individual programs. So I don't know if the panelists you've all kind of alluded to a lot of these things already, but maybe speaking a little bit towards family friendliness and how when you're interviewing, you can go out determining that a department is family friendly. Like, what does that actually look like when you're searching for a job or a residency program?
I can speak having recently gone through this. I just asked people when I was interviewing, if someone's gone on a recent maternity leave, what did that look like? And I just asked the question and I got zero resistance from having that question answered. And I had a relationship with the places that I interviewed at that point. I wouldn't come out of the gate with that question. But I think that people need to know that. And I think it's part of your job search. And it's, as Dr. Jagsi was saying, it's more, I think, becoming a really important decision-making factor. For me personally, I felt like time off was almost just as important as the salary was when I was interviewing. And so that was a big part of my negotiations, was negotiating a week of rollover into my vacation time with the knowledge that I would likely want to grow my family in my early career or in my career at some point. So in private practice, my incentive to take off is very low. I will be able to take FMLA should I choose to, but after I kind of extinguish my vacation days, there would be no financial income. So planning for that is going to be a huge part of my, planning for family growth with early career. I think that there's a lot of flexibility with that if, you can plan for that in advance. Clinic coverage, I think finding a place that values family is so important, and having the support of a group that is going to be able to step up for you during that time off is extraordinarily important. So just having a good sense of, do the other people you're going to work with and the leadership have families? What are their values for taking time off with their families? And those are things that you can gather just by spending time during the interview process with them outside of work, maybe at dinners, or if you can, come back for a second look and have time with their families, you can just see if your values align with their values, and that's super important.
Can I add something real quick to what Ashlyn said about clinic coverage? This is very practical. Like radiation oncology, unlike surgery, has this like interesting ability for us to like remote in, do volumes and notes and stuff like that. But there's also this, part of our job where if you're treating patients, someone has to be there, right? So if you're in a large practice with division of labor and someone can be there, you can go home at 3 or whatever it is to meet your kids at the bus and be home with them from 3 to 6, and then get them eating, and then you can go remote in and do your volumes, right? So that's the beauty of radiation oncology. So there's an advantage there. But if you're in a very small practice where someone has to be there and the treatment times are long, then all of a sudden you're handcuffed to the clinic. So I think that's just really important to think about clinic coverage in different ways, because this is sort of an hour by hour thing. And we've focused a lot about like pregnancy time and postpartum time and all that other stuff. But kids, they hang around for a long time. And, when they're 12, 13, they still need you when you come home. And so I think the broader family planning concept, involves sort of thinking about flexibility, clinic sort of with your kids in those sort of like, post-school before bedtime hours. And RadOnc is awesome for that, potentially, if you have good, coverage in the clinic.
I think some other questions coming through in the chat that are related to this surround updates to the ACGME policy, as well as the ABR time off clarification. One attendee was asking specifically how is 6 weeks mandated by ACGME. It's actually a part of the updated institutional requirements that if you are an accredited residency program, those are the requirements sent out to programs, is my understanding. So that's
it's for the institution. So if you're a sponsoring institution, you have to have a policy in place such that all of the programs, which includes radiation oncology, are providing that amount of leave, paid leave.
Perfect. Thank you for that clarification. So that was one chat question. The other question involves, let's see, if you're toward the end of training, do you suggest taking a job contract secured before having children? Or is it possible to take time off and plan for that as you're negotiating your contract? Like if you were to have a child in the summertime, could you start later, for instance? I think I'm interpreting that correctly.
I did. I gave myself a self-paid maternity leave, but I did sign my contract. I was pregnant as a chief resident, signed my contract, and then asked if I could start a few months later. And that was viewed okay. I think if I had it to do over again, I would have probably gone to I might have asked for a parental leave during my first year that might have been supported by the institution. I think, it's interesting. We certainly support people to do other things that we think are important, and making them, whole human beings, I think, is important. So I certainly think you can do that, but there might even be more favorable things that you could work out.
I think one interesting aspect to this question also is taking time after residency. So implying a somewhat of like a job gap. And I think that's a little bit of a different question. I'm wondering if anyone has any thoughts on that.
Yeah, it's Bill. I don't think anyone really thinks of a gap as being viewed negatively if it's not 2 years and you lose your skills. I mean, a reasonable gap is probably okay. Probably the more difficult thing is, and one thing we have to advocate, most of the hospital systems in the country now are not doing very well. I know our system is losing money and a lot are. So we don't get approval to hire someone until we absolutely need to. So it would be tough to give someone a significant gap time when we're really needed that person to come in. So there are some logistical things that come into play now that maybe didn't back when people were having hospital systems were having 7% margins. So part of our advocacy really has to be advocacy for funding, advocacy for CMS to make insurance companies pay the extra money for residents. I mean, there's some certain things that should happen that would make a lot of these things much easier, but that's my, so our advocacy goes throughout the whole continuum of our policies.
I think that's a really important point. Another chat question that came in is kind of a topic that came up earlier and gets at the length of leave. Specifically, getting at time-based training versus competency-based training. So if you look at ACGME requirement of 36-month clinical training with 12 months of research or elective time, the question is, how would taking parental leave necessarily impact that clinical time if you were to take time out during clinical training versus during the elective time?
So I'll start if that's okay. I mean, I think one of the things that is important to the whole residency process and feedback for trainees is, the committees that exist, often led by the program director, or if there's an assistant or associate program director. So you have, your clinical curriculum committee, and you have a program evaluation committee. These are all requirements for accredited programs and RADONC. And one of the main things the CCC does, right, is evaluate residents, make sure that they are meeting their milestones for each of the PGY years. And, again, that is something of a moving goalpost as the milestones, and that's a separate conversation for another day. The milestones for radiation oncology are evolving and becoming, I think, more useful and more specific. But at the end of the day, rather than thinking about time-based competency, it's, using these milestones to determine that a given trainee has achieved competence in, this particular area. And so we are going to do what we can to make sure that their training is complete, even if there are, X number of weeks that they had to take. And certainly, family planning and parental leave is one thing, but there could obviously be other events that may happen during your training that require you to be away. And so it has to be looked at, the totality of it has to be looked at. And there's nothing in the ACGME rules that says that the program director has to, count every single day, every single hour. The idea is that if something less than that is done and it can't be made up for in the 12 months, something less than the 36 months of clinical training, results because of leave, and those, for whatever reason, 12 months of research and elective time can't be used to make up some of those 36 months, then, you have that conversation with the resident, with the program director, with the entire committee, and speak to the ACGME about, what particular issues are and work that out, because, most times you are able to borrow from those 12 months and kind of fill any gaps that may be there. But I don't think there's anywhere that says you must have exactly X weeks on this particular rotation, because that's the only way that you're going to achieve competence. We recognize that that's a different pace for different, it's a different pace and it's a different skill set for different trainees, that, where they have their strengths and where they have their relative areas for improvement. So again, I think between the committees that exist and the milestones that exist, there's actually, I think, a environment now in our training that supports the use of these weeks of leave. Whereas previously, when it wasn't sort of that setup, people relied much more on the strict times and just sort of said, well, you have to have your 36 months and that's it. And that's just not how it's perceived now.
I think one question I would like to bring up from our panel, given the experience that you all represent, is how parenthood changed your career goals or not. I know one thing that we brought up earlier was how many young parents find that their career goals change because of their experiences and the demands of parenthood. And I would love to hear from you all from an academic, from a private practice standpoint, what that was like for you and what advice you might give the trainees who are listening today.
I'll go for this one. I will say that I actually thought that I would want to work part-time as an attending. When I was in residency, my first year, I remember Simon Powell and Alphonse Tagian, the two breast attendings who had a really great project for Astro. And they came to me with that project. I was a first year resident, I was on the rotation. And they said, you know, we want to give you this project, but we kind of want to know, like, do you think you're going to do breast? Because it's a really good project. And like, you know, we want it to go to someone who's going to do breast and like stay academic. And I did like the total opposite of Sheryl Sandberg's lean in. I was like, I don't know if you should give it to me. You know, I haven't had babies yet, but I think at some point I'm going to want to have babies. I hear that your priorities change when you have babies. Like, maybe you should just give it to someone else because like I can't commit. I might want to work part-time. And Simon Powell actually stepped in and he's like, I'm not really sure now why we asked you that question, because hearing you just makes me realize we know you better than you know you. You're never going to stop being intellectually curious. You're never going to want to stop doing academics. We're just going to give you the project. And like, yeah, sure, you can think you're going to want to go part-time. You know, I thought I was going to want to and need to do that. I was also very fortunate to have a very supportive partner. And then over the years, to see what my being in the workforce was actually doing for my kids. So first of all, I'm kind of intense. So you don't want to be my project. You do not want to be my exclusive focus. Like if my children had been my work, if they had been my focus, I think I would have like broken them. Instead, you know, they saw me focus on my career. You know, both of my kids were surprised. One of them my daughter came to work one day and saw one of her little friend's dads at work. And I said, oh yes, Dr. Hamster is one of my partners. He works here too. And she said loud enough for everyone to hear, oh, boys can be doctors too. And those kinds of things actually just motivated me to work more. So I don't know that you can necessarily predict what becoming a parent will do. It does completely change your perspective. It makes you future directed. It makes you think about what impact you're going to leave and what kind of world you're going to leave for your kids. But for me, it made me actually do things that I would never have imagined, moving to another city while my kids are still living and going to high school in Ann Arbor. I mean, I'm flying back and forth. And I'm doing that because they said, Mom, go do that. So that's that.
So from a private practice world, I'll just speak because I think I'm the one represented on the panel. Our motivations are a little bit different from a career standpoint. We're not doing research. You know, my clinic that's my job, very clinic heavy and clinic focused, and then have a lot of business development to try to reach out and have good connections with other doctors. And a lot of what I love to do outside of taking care of my individual patients is actually educating our community physicians on what radiation oncology is and how it can be useful. And then being closer to training, keeping everyone up to date with the latest literature, since I feel like I still have somewhat of a finger on the pulse of new data. So I agree with Dr. Jaxie that being a mom and being a physician is obviously hard, and there are some things that you compromise on, and there's laundry that's not folded and dinners that are takeout instead of homemade beautiful meals, and that's okay. Everyone's fed and everyone's happy. And to be honest, I doubt my child cares. And I know my husband doesn't because he's very supportive. But I think that the moment this year that really showed me that it's okay to have both and have compromise in both. My daughter, as she's learned to speak, now when I come home, she asks, Mommy, how's your patients? And she knows that I'm going to take care of people and help them feel better. And it's just I don't know, it's a really cool thing to be able to show the next generation that they can be compassionate and kind and working, you know, to do that for my patients. My daughter sees that, and it just helps me be a better mom.
I think we only have a couple minutes left. So I know as a part of the wrap up, one of the things we wanted to ask the panel was if there's anything else you wish you'd known as you considered family planning in your career, or what advice would you give to prospective trainees?
it doesn't hurt to ask for what you want, I would say, at your program or in your job. Like, if you don't ask, you're not going to be told any answer. So if there's something particular that you would like that would help you with family planning, I would just go for it.
Yeah, I would echo that it's so important to, be able to be upfront about this. I think the time now is such that I think it is absolutely not only appropriate, but I would hope expected, that you be able to ask these questions and not feel at all intimidated or concerned about how they would be perceived. And I know it was brought up before about how do you even get a sense of, the family friendliness of a department. Well, you can tell a lot, by the people that stay and the people that choose to go there, and how it is that it's, become a part of the culture and become a priority within the department. And I know one of the things that I really appreciate is how much all of my colleagues, my husband included, but all of my colleagues are open about when they need to take off early because they have to pick up a child, or sorry, I couldn't come in because, I'm sick. And I remember feeling like so many of my, I guess, initial more insecure years as a brand new faculty member and a young child, thinking that if I brought that up, I would immediately be seen as not being committed to my career. And there's nothing more liberating and more, I would say comforting at the end of the day than hearing your other colleagues and the fact that they don't have any hesitation in sharing what's going on and being able to balance. Yes, I can't be on the Zoom because I need to go to a therapist, and that's okay. And the more that happens in an environment, I would say, the more you can feel that they'll be supported when it's your time, when you need extra help and you need to lean on your colleagues to cover for you. So to the extent that that's something you can ask about and sense and observe, that would be my advice, is to really seek that type of place. And they are out there, those environments are there, and even the ones that maybe historically weren't that way, I think recognize, as you heard earlier, I think the pandemic has brought a lot of this into focus for individuals where perhaps previously it wasn't. So I would hope that is only a further boon to the normalization of all of what we need as personal individuals, and also how that impacts how present we are at work, right? Forget the physical presence, but to be mentally and emotionally connected to your work, you need to know that things are all right at home. And it's important that every employer, recognize that.
Yeah, can I tag onto that real quick? I think as, sort of the dads and future dads that are on the call, and just, as like, men in medicine, it's really important to sort of, again, normalize the fact that people have kids, and when we all sort of like pretend they don't exist, like doesn't do anyone any favors. I think one of my favorite conference calls that I had on this probably like 7 or 8 years ago was like a big cancer center conference call. Everyone's on the call. And it was like one of my like famous unmute moments where I'm like, just eat your granola bar. Like, you're not going to get any like breakfast. And everyone just like starts cracking up. And I'm like, oh, whoops. But, like the fact that people like witnessed that, and again, all the people that were on the call, I got more positive feedback from like literally like, showing that vulnerability, like, hey, I'm a dad, I'm struggling. I have to like yell at my kids to try to get them to eat breakfast because I'm like trying to run out the door, get them to school while I'm on a conference call because you have this call at some ridiculous hour. Like, look, if you want me at, this hour, you're going to have to hear me yelling at kids as I'm trying to get them to school. Like, I think that normalizing that and say, hey, look, I got kids in the backseat, like just keep the, anal words like to a minimum on this call right now because we got kids in the car. Like, normalizing that and just sharing, like, look, we all have kids, and not like pretending that they don't exist, I think is, a positive for, all the parents that are out there.
And I think just from a trainee standpoint, the thing that's been really imperative for me was having mentorship in a personal life setting, not just mentorship for research and for clinic, but someone who could help with questions about work-life balance and how you achieve some of these things. And whether it's peers who were also residents who are a little more advanced than I was, or early career attendings who had kids within weeks of me, which I have at my institution and I'm lucky to have, that support is really invaluable. And I've learned more potty training tips from some attendings on clinic days than I have about contouring, just because that day was what was really needed. And I think finding that environment of support where you have a mentor who not only serves the role of educating you professionally so you can succeed as a radiation oncologist, but also knowing who you can rely on. I have hand-me-down baby stuff from my attendings. I've gotten stickers that say you're the exact mom that your kids need. And it's that environment and finding those people who will be in your corner that I think has helped me to be successful in balancing academic research, clinic, being involved in organizations, being a parent, and feeling like I can do all of those things without absolutely losing my mind. Although, I mean, we all have those granola bar moments too, where it's all a struggle.
Thank you all so much. I know we're just coming up on the hour. So a lot of the organizations referenced here, which a lot of our panelists also represent, have great mentorship programs. So I think that's a great piece for us to end on. Mentorship is important, just as Dr. Beltran was alluding, having personal life mentors to help you navigate these complex transitions. And with that, I just want to give a hearty thank you to our entire panel, Emily McDuffie, my co-moderator. Thank you guys for spending the afternoon with us and taking time out of your busy day. To all of our attendees, if you don't mind either using the QR code to fill out a post survey giving feedback on the session. We'd love to know what you learned and how we can make this better for future iterations. And then last but not least, thank you to my Roper organizers who will be having another amazing session next month. So thank you so much to everybody for joining us today.
Thank you.
Bye, guys.
All right.
Bye.
Thanks, guys.
Take care.
With that, have a good